Well, thank you very much for the introduction, and to you, Professor Bushfia, and to Dr. Jedan for the possibility to present Epimune and our technology to you. Again, sorry, I don't speak French, so it's going to be in English. So what? Okay, so how do I do that? Oh, here. So we are a small company. We are based in Berlin, Germany, and the technology that I'm going to introduce to you has actually been developed over the last 20 years. And the vision that we have is this. Oh, okay. Yeah, thank you. Is that we want to help, at least, or maybe revolutionize how we can early detect and monitor patients with immune disorders. And this is fairly broad because we are certainly thinking a lot about primary immunodeficiency, but also acquired and other immune defects. And the technology I'm going to describe is called epigenetic immune cell quantification. So the limitations that we see, obviously, is that when it comes to a deeper phenotyping of immune cells, flow cytometry is the gold standard. There's no question about it. It's a very powerful method. But in the early stages of the diagnostic chain, it is usually not being done. It's not part of your routine checkup. You get your complete blood cell count, you get a differential, but you usually don't get an immune phenotype. The equipment is usually, at least in our experience, available in larger clinical centers, not in the smaller, more regional clinical centers and laboratories. And this is most importantly, it requires a fresh blood sample. So you need to have the blood sample in the lab within 24 hours to get it analyzed. It needs well-trained personnel, high capital investment, and the standardization can be difficult between labs. Our approach, epigenetic, I'm going to show you a little bit more. It's a molecular approach. It's PCR-based. And as you introduced correctly in the introduction, it works on dried blood spots, or basically any sample where you can isolate DNA from. So it could also be isolated DNA, frozen blood, you name it. Using dried blood spots, this also allows self-sampling. So we are seeing more and more, especially after the corona pandemic, we see people being more open to taking samples at home or in a pharmacy. So using a finger prick and putting the blood drop on a piece of paper could allow self-sampling without professional use. It simplifies sample logistics, so the sample is very stable. It allows standardization. And we want to believe, and this is why we are here, because we want to believe that we can help in the very early stages where people are presenting with symptoms of immunodeficiency, that having an easy, low-hurdle approach to immune phenotyping can help to detect immunodeficiencies earlier. And it's also suitable for newborn screening. So how does it work? We use DNA methylation markers that are specific for the target cells that we want to detect. On the right-hand side, you see the yellow bars are regions in the genome that are specifically demethylated in the target cells that you see at the bottom. And when it's blue, it's methylated. When it's yellow, it's demethylated. We also use a housekeeping gene, GAPDH, for quantification purposes. And from a laboratory perspective, it is a standard real-time PCR process with one additional step, which you may be familiar with if you ever worked with epigenetics. It's a treatment of your DNA with a chemical bisulfite, which basically converts the methylation signal into a sequence change. And then you simply design the primers to only amplify your target cell and not the other target, the non-target cells. So that's the principle. Over the last almost 20 years, we developed a range of different markers. This is where all the work goes in. So we have covered several parts of the, of the adaptive and the innate immune system. You can visit our website. There's always an updated list of those assays. But out of these 22 markers, we decided to select for clinical application a standard lymphocyte panel that I think most of you or all of you know in clinical routine. It's the classic lymphocyte panel, T cells, B cells, and natural killer cells. So this is an in vitro diagnostic kit that we registered with the European in vitro diagnostic regulations. We are introducing it worldwide in all the different markets, and we are also having a partner here, Molecular Experts in Casablanca, who is introducing the test here in Morocco. What you get is something you should be familiar from flow cytometry. You have your reference ranges in healthy individuals, which are the colored bars, and then you get your individual patient samples result. We see very good correlation between flow cytometry and the epigenetic approach. This has been published as well as in several clinical cohorts that we have done since. And we see very good correlation both for relative quantification as well as for absolute quantification. So I do need to say or to add that for absolute quantification, we actually currently need a liquid blood sample, or it can be frozen. On the dried blood spot, we are currently doing relative quantification only. Just another cohort, these were actually primary immunodeficiency patients from our collaborators in Germany. We also see very good correlation with flow cytometry and our technology. We also designed a smaller version by taking out the B cells and the natural killer cells and just focusing on CD4 and CD8 cells. Obviously, this would be something that could help in monitoring of HIV patients. And we also did a pilot study where we took the remains of plasma separation cards that are being used for HIV viral load testing. And from the same sample, we could also determine the CD4 and CD8 counts. So this, we hope, could be an added value if you do viral load testing and do CD4 and CD8 testing from the same sample. Again, correlation with flow cytometry in HIV patients also very, very good. We also developed a kit for dried blood spot collection. This is ready to go. You can send it to your patients or give them or send it, and they can return the dried blood spot sample here on a filter card and send it back to a laboratory. And finally, we are also obviously thinking about very early detection of primary immunodeficiencies, so in the newborn setting, by being able to work with dried blood spots, newborn testing is a possibility. And we have shown in collaboration with our collaborators in the Netherlands, who have been using our test to, at the moment, as a second-tier test after SCID screening. So they are using, or as many countries, they're using TREC for SCID screening, which produces a fair amount of false positives and also non-actionable findings. And we could show, and they could show, that we can reduce the false positives and non-actionable findings significantly. So just to wrap things up, just to reiterate why are we here and why we are very happy to be at this great conference, is we really want to help the current limitations that we see in early detection of primary immunodeficiencies. So to our understanding, and you are much more the experts here, is we are currently losing a lot of patients because they are not being suspected having a primary immunodeficiency when they present at the general practitioner or at the dermatologist or pediatrician or wherever. So we are using anywhere between 70 to 90%, which leads to repeat infections, hospitalizations, etc. You know that. So our goal really is to shift that down so that the majority of patients that show up go into the right diagnostic chain, and we had just heard in the previous talk the necessity and the excellent power of molecular next-gen sequencing and other diagnostic tools to eventually do the diagnosis. So this is really important. I think our test, which is a standard TBNK panel, can never replace a deeper phenotyping by flow or a molecular diagnosis. So it's really an early test where we hope to increase the early detection in a screening setting, both in adults or in newborns. And just to finish off, I'm sure you're aware, but a couple of years ago, the WHO included quantification of T, B, and K lymphocytes in their essential list of diagnostics to improve early detection of primary immunodeficiency. Okay, I think this is my last slide. Just to reiterate, it's a simple process: dried blood spots from finger prick or neonates, put it on a card, send it to a lab, and get the results within the day. And these are just a few of our collaborators and sponsors that we have been working with. And I'm at the end of my presentation, and thank you very much